The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of those and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Like Moron Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to the Curbsiders Internal Medicine podcast, where we use expert interviews to bring you clinical pearls and practice-changing knowledge. And today, we are actually going to give Matt and Paul a break and bring you an episode from the Curbsiders Addiction Medicine, our mini-series on substance use disorders. So today, I'm Dr. Carolyn Chan, and I am joined by my co-host, Dr. Ira Krishnaskaya. And on tonight's episode, we'll discuss updates and nuances of the care of patients with methamphetamine use disorder with Dr. Phillip Coffin. But before we get into that, Ira, will you remind the audience what we do on this mini-series?
Of course, Carolyn. We are the addiction medicine podcast that uses expert interviews to demystify common addiction medicine topics, reduce stigma, and inspire learners to be fierce advocates for all patients living with substance use disorders.
And a friendly reminder that this is our season 4 of the Curbsiders Addiction Medicine, and it is brought to you by the American College of Academic Addiction Medicine. ACAM provides educational resources to help you deliver evidence-based care for patients with substance use disorders. Strengthen your clinical knowledge with the ACAM didactic curriculum, which features expert-led sessions on managing substance use disorders in real-world settings. If you're looking for board prep tools or just interested in testing your knowledge or your team's knowledge on key concepts, be sure to check out the ACAM question bank. Learn more at acam.acam.org.
And Dr. Phillip Coffin, our amazing guest today, MD, MIA, is a board-certified and practicing internist, infectious disease specialist, and addiction medicine specialist. He directs the Center on Substance Use and Health at the San Francisco Department of Public Health, including clinical trials assessing medications for multiple substance use disorders, interventions addressing drug toxicities, and disease prevention and treatment, and substance use epidemiology. And man, Carolyn, what an episode we have. Dr. Phillip Coffin teaches us so many things. 2 quick points. He taught us to ask first about the benefits of methamphetamine use disorder, and that in our back pocket, the 3 medications we should be thinking about initially with treatment is mirtazapine, bupropion, and naltrexone. What about you? What are your pearls?
He gives us this incredible framework to actually discuss with our patients and review their stimulant use. So his 4-step approach involves assessment, preventative care, use and reduction in treatment, and finally toxicity preventions.
4-tier approach.
A reminder that this and most episodes will be available for CME credit for all health professionals through VCU Health at curbsiders.vcuhealth.org. And on that
note, without further ado, let's get to it.
Phillip, we are so excited to have you here today. This is the lightning round where we like to ask our guests a couple of questions just to get to know you a little bit better. So I was wondering if you could give us a one-liner about yourself.
A one-liner about myself? Let's see. I'm a physician, researcher, father. That's most of my time. And I guess in the free time I have, I like to kite surf in the bay and do stained glass and go to fun events where I get to dress up in different ways.
Whoa. You have to tell us more about that last one, Phillip. That was amazing. A little teaser. What kind of events are we talking about?
It was in the vows in my marriage that we would costume. That was one of one of the vows.
Okay.
So I think some of the great Bay Area events are like the Edwardian Ball that happens each year in January. Other sort of Burning Man adjacent events, and Halloween, of course, is the big one, and multiple parties and multiple opportunities for fun stuff.
Are you a Beta Breakers person? Do you dress up for that or not really?
When I was in medical school, I dressed up for Beta Breakers. Me and a fellow medical student, we dressed up as losers. We wore pocket protectors. We had, tucked in shirts coming out the bottom of our shorts, and had kick me signs on our back. It was really fun.
And maybe I should know what this is, but what is Beta Breakers?
It's bay to breakers.
Oh,
It's
okay.
it's a race that most people don't run in, but instead walk, and includes a delicious array of San Francisco extraordinariness.
And somehow, despite being here for residency, chief year, and like 8 years on faculty, somehow I have never been able to make beta breakers, whether I've been working or out of town. It's always missed. I've always missed it. But the costumes that many of our UCSF people have put together have been, and it sounds like including potentially a loser-like costume, have been very exciting. So that's pretty awesome. Thanks, Philip. Do you mind sharing maybe a favorite failure that you've had in your career, and it can be medicine or not, and what you learned from that?
Let's see. I love kite surfing, and I'd say probably some of the injuries I've gotten kite surfing feel like failures. Uh, the orthopedic injuries that keep racking up through the years. In terms of medicine, we all have those cases we wish had gone differently.
And I'm curious too, what's brought you to the field of addiction? I feel like a lot of us have had different paths. What sort of made you interested in this field, and how did you get to this really cool place where you get to do all these awesome things with your time?
I actually got interested in substance use. The first class I ever walked into as an undergraduate a long time ago. I had entered undergraduate thinking I was going to go into engineering, arrived at school, dropped every class that I had signed up for, and found a whole bunch of new classes to sign up for, including one that the RA in my hall, in my dormitory, suggested I sign up for this class called Drugs in Society, said it was really cool. It was taught by this ethnographer. And I remember vividly, I didn't, it was first class I went to. It was an evening class. I had just come out of the cafeteria where I had never actually been in all you can eat cafeterias. So I had took a bunch of extra food with me. And I also hadn't been to a college class. So I took all of my books for the entire semester with me, which was about 12 books. So I had 12 books and a half a dozen bananas in my bag. So all of my books for the entire semester were soaked in banana. But what hooked me was, this is back in, a long time ago when syringe access was not legal, and every state had laws against needle access and possession. And the story that these laws had led to HIV outbreaks among people who inject drugs, it horrified me that the government would enact and enforce policies that harmed people like this. And that's what hooked me in. I proceeded to develop an independent concentration and develop coursework around this topic and kind of weave it into everything that I did in a multidisciplinary manner. And then I was lucky enough to get out of school and start at the Soros Foundation in a drug policy, basically sort of a drug policy think tank and a development program. I got to assist in developing a harm reduction network and programs in former Soviet states, as they were called at the time, because this was soon after the wall came down. And then did an international affairs degree and then transitioned into medicine. I tried to get out of the substance use and addiction game during my infectious disease fellowship, but it's pretty addicting.
Like you said, it just hooks you in.
It just hooks you in. Yeah. Yeah.
To think it all started with 12 bananas and a bunch of books. So
That would be the memoir or the title of the future album, who knows? Or the dance, the costume dance that is kind of a representative of your career, Philip, if you wanted to have one. I feel like that would be a great topic or a great title.
The banana soaked books.
Exactly. Or, a band. It depends. Well, maybe from the banana soaked books, is there a meaningful piece of advice or feedback that you received during your career training that you want to share with our audience before we move on to the case?
I guess I just think if you're lucky enough to love something and be hooked by something, don't let it go. Not everyone gets that kind of fortune, and it's powerful when you run into it. And it keeps you going through the more challenging times.
I feel like that is great advice for the world we're all living in right now. And on that note, I think it's a great time to actually start our case. Ira, do you want to kick this off?
100%. Thanks, Carolyn. So we have a case from Catchlock Memorial, Phillip, for you. This is John. He's a 31-year-old man who presents to you in clinic, history of methamphetamine use, saying he smokes a little crystal weekly. Also has a history of depression, difficulty concentrating, and a recent ED visit for somnolence and slowed respirations. His symptoms resolved with naloxone administration and were concluded by the ED team to be a result of an unintentional fentanyl exposure. And John comes to you saying he's noted times in the past where his methamphetamine use got in the way of his school or work, and even times his relationships, especially with his friends. But it really never brought him close to dying, and this ED visit scared him. So he wants to talk to you more about it. And I think, taking a step back for us, Phillip, before launching into this conversation with John, can you maybe share how you're thinking about his presentation, both his history, that ED visit, and maybe kind of broadly what's going on in your mind when you hear his story?
Sure. So there's two issues, the ED visit and the unintentional opioid exposure, presumably fentanyl use, and the overall issue around his methamphetamine use that brings him in to see me. From what you said, he already meets some use disorder criteria because he has some problems in his life that he attributes to his methamphetamine use. And so he's already met a disorder criterion. Although, to be honest, I would address his use regardless of whether or not he qualified for a use disorder.
And for our young learners out there, our med students, et cetera, do you mind just giving us a brief reminder of use criteria? Like, what does that mean? What criteria are you talking about?
So I like to divide the 11 use disorder criteria into 3 buckets. The one bucket is tolerance and withdrawal. Those only apply if you're not prescribed the drug. The other bucket is the use characteristics. That means, do you tend to use more than you mean to? Have you tried to cut down and haven't been able to? Do you spend more time than you mean to trying to get or obtain and use the product? And do you have cravings? So that's 4. And then there's 5 within the sort of problems that result from your use, including activities, relationships, responsibilities, physical danger, and health problems. As an example, I had a patient once who used methamphetamine every single day for decades, but his only criterion was his teeth, which were rotten, and he attributed it to his methamphetamine use. He could stop when he wanted to. He never felt the need to use more. He never had cravings. He had no other issues. He had no withdrawal if he stopped. And he could stop when he got a new job to get urine tested. So he only met one criterion. He didn't have a use disorder, but it was still really important to address his use.
I think that's a great reminder for everyone that not everybody who uses drugs has a use disorder, that they're really specific criteria, and we really have to see those like problems and consequences in order for us to think about it as truly a disorder.
Absolutely. And I think it still can be really important to address the use.
Totally. And I feel like that kind of component of whether is it loss of control, whether it's chaotic use, you kind of want to get to the root, and you also want to hear more about kind of the type of use. And I guess, Phillip, what would you be thinking about to ask John, or kind of hear more about his story in terms of the use itself to really make this diagnosis?
I always start, particularly with stimulants, I always start with what benefits do you get out of your use? In contrast to many other substances, stimulants have a functional role in people's lives. Most of us have consumed stimulants most days as adults. We have a cup of coffee or tea or whatever it is, and we're using it to try to enhance our function. So he might be using methamphetamine to work his job, to clean his house, to stay safe on the streets, or whatever it is. Or he might be using it for pleasure purposes. Regardless, it's really important to understand why he's using it and what the benefits are. Because in some cases, you're not going to overcome that, or you're going to have to try to find something to replace it, because it's a benefit or a functional attribute that he's not going to feel that he can live without. The next thing that I try to get at is the cumulative exposure and binge pattern use, which kind of brings me to what I'm concerned about with methamphetamine use, which is the overall toxicities. The deaths from methamphetamine, they're not really overdose deaths like we think about overdose deaths, but instead they're mostly more like alcohol-related deaths. They're deaths that happen from cumulative exposure and are exacerbated by binge pattern use. So I want to get a sense of how much exposure has he had to methamphetamine. If he's using a little bit once a week for a couple of years, that's not a lot of exposure.
Mm-hmm.
If he's using a gram a day for the last 20 years, that's a good amount of exposure. So I actually like to calculate a gram year history for people. In the San Francisco area, methamphetamine is about $10 a gram. So if he says he spends $10 a day on methamphetamine and he's been using for a decade, he's got a 10-gram year history, that's a reasonable amount of exposure. And it's going to make me think differently about the potential consequences and medical complications he may have.
And how do you counsel patients on some of those short-term and long-term impacts of stimulant use? Because like you said, it's cumulative. And I think sometimes it isn't always obvious to our patients. And sometimes I feel like I don't do a great job explaining like what these risks are and look like over years of heavy use.
It's a great question. And you're leading me into my what I think is really exciting about managing stimulant use in medical practice. I explicitly use a 4-tier approach. And I'll tell patients, I have a 4-tier approach to addressing your methamphetamine use. And so the assessment is the first one, obviously. The second is screenings and vaccinations, all your sort of general preventative stuff that anyone who uses drugs should get. And that is kind of like all the extra stuff you do for somebody with diabetes, so that even if they don't get their sugar controlled, they're going to live longer. The third bucket is the use reduction bucket, and then what we think of as sort of treatments for a use disorder. And the fourth bucket is toxicity prevention. And I go through them in order. And when I get to that fourth bucket, it's really exciting and novel to patients. And it engages them in ways that I've never experienced before. I summarize the toxicities for methamphetamine into 2 categories. One is cardiovascular, and the other is neuropsychiatric. And both are going to be influenced by some of the same phenomena, such as cumulative exposure, as well as binge pattern use. So I do need to know, do you go on runs? How many nights do you stay up in a row when you're using? Some people just use in the morning to get through the day, or in the evening and sleep every night. Other people use for 5 days in a row sometimes. And as we know from our medical training, staying up all night shortens our lifespan. So obviously, it's going to shorten the lifespan of somebody who's doing it using methamphetamine. So in talking about those 2 sort of categories of toxicities, I bring up the potential things that we can do to try to prevent them. I like to talk about, of course, use reduction is going to be the best way to prevent those toxicities. But good sleep is really important. And I was trained in an era where we try not to use pharmacologic aids for sleep. And I wonder if I'm too conservative on that. And maybe in these cases, sleep is so important that I should overcome some of my reluctance and be more aggressive in trying to help people get good sleep. Another topic, of course, is smoking cessation. So a lot of people are smoking at the same time, and we understand well that cardiovascular risk. And then the third is statin medications. My cardiologist colleagues are going to resist this. I do not have controlled trials with 30,000 people, but there is enough of a mechanistic suggestion and animal model data to suggest that statins probably reduce the cardiovascular toxicity of methamphetamine. They certainly reduce at least some of the cardiovascular toxicities of cocaine. That's been shown. And also some of the neurocognitive and neuropsychiatric dysfunction that we see. So for the neuropsychiatric dysfunction, we're talking about psychosis, cognitive decline, and Parkinson's. Psychosis, I don't have any evidence that statins would affect, but the cognitive decline and the Parkinson's do appear to be slowed by statins from animal models and human data.
And Phillip, if I can summarize for you, because I love this kind of 4-tier approach from the very beginning of like the assessment, kind of doing the preventative care, doing the use reduction or kind of use treatment, and then the toxicity prevention. And it sounds like when you kind of zoom into the toxicity prevention, I got like 3 S's going, like addressing sleep, addressing the smoking, and addressing the statin, like are you con or sin statin? So I think that's like something we can really kind of summarize for our audience there. If we can take a quick step back in John's case, when you're thinking about him coming to you and, let's say he happens to be based loosely on a patient that I might have taken care of in San Francisco, but let's say this unintentional kind of fentanyl exposure happened in, the area where you practice. Does that fit with your kind of current understanding of the drug landscape, especially for people who are using methamphetamine? And how does that fit into your like tiers? Like, is that kind of going into like the maybe preventative, like preventing kind of exposure to fentanyl, or how does that fit into the model that you just really nicely outlined for us?
It definitely is a common phenomenon, this unintentional fentanyl use. And I will say I use the phrase use instead of exposure because fentanyl exposure is often used by this misconception that being in the same room with somebody who uses fentanyl or touching fentanyl powder will somehow cause an overdose, whereas fentanyl doesn't absorb well transdermally. In fact, the data suggests you would need to stick both hands into a bucket of fentanyl for 10 hours to get a significant dose. So this idea that, fentanyl exposure is causing all these overdoses is offensive and really, frankly, stigmatizing for people who use drugs and leads to policies and medical care that are really poor and harmful. So we use the phrase fentanyl use, and what we see in the paramedic data is that about 40% of confirmed opioid overdoses are among people who deny any opioid use. In my paradigm, you're right. It fits in that sort of prevention bucket with screenings and vaccinations, and everyone gets naloxone. If you're using non-prescribed drugs, you should have naloxone on hand.
And thank you so much for teaching us that piece about fentanyl exposure being really stigmatizing in the term of kind of fentanyl use. That's super helpful and really appreciate you kind of walking us through that, Phillip. Well, because we're all on the edge of our seats for that third tier or that third component of your tiered system for use reduction and maybe use treatment, could we take a journey down that lane with you, Phillip, in terms of how do you initiate even that conversation with John, whether it's psychosocial treatment, pharmacologic treatment, or even the conversation around use reduction?
Yeah, my sense is from John's arrival that he's interested in not using methamphetamine. That is most likely why he's coming in to see me today. And think about treating stimulant use disorders or methamphetamine use disorders, or even helping somebody reduce even if they don't have a use disorder, but they need help to reduce, through first contingency management if we have access to it. And then after that, there's two main drugs that I think about: mirtazapine and bupropion, plus or minus naltrexone, injected or oral. And then anything beyond that kind of gets you into the addiction medicine consult world. But those three drugs of mirtazapine, bupropion, and naltrexone, in theory, could be handled by a primary care outside of an addiction consult setting.
I'm curious if you could walk the audience through what contingency management was, because I don't think I really understood or learned about what this really cool treatment modality is, honestly, until I was in addiction fellowship.
Contingency management has been studied for many decades and has many dozens of trials proving that it can reduce stimulant use. Stimulants are probably where it's the most effective. And it involves basically giving people money or prizes or raffle opportunities for a desired behavior. In this case, let's say not using a drug. And there's a few really important elements to it. One is it has to be timely. So you don't want to send a lab off and next week say, "Oh, your lab was negative. I'm going to give you $5. So you want that positive reinforcement to come really on the spot. So you need point of care testing. The next thing is the reward has to be meaningful. If you're giving somebody 50 cents, that's not going to work. If you're in San Francisco, you probably need to give them $5,000. You're just kidding.
We're actually not kidding, but yes, go on.
So, and what we've seen in California, fortunately, we have a Medicaid pilot to support contingency management programs. Unfortunately, that's only in addiction treatment settings so far. We're trying to expand that to FQHCs. And for now in San Francisco, we have local funding to support some contingency management programs, some in the community and some in clinic settings.
And I love, Phillip, that you bring up contingency management first. Like, that's huge because I think that shows, well, one, it's the most evidence-based approach, but I love that that's like your first approach. I wonder, do you ever pull up the recent ASAM, AAP clinical practice guidelines on the management of stimulant use disorder when talking to your patients? Or is that something that you've, committed to memory and so therefore don't need it because you can just reference it immediately to kind of guide your counseling and your thinking about this?
We've created a little flow chart that I use sometimes for patients, but I like to write things on a piece of paper or a whiteboard if I can and create them in the moment for patients. That's really how I like to do it. The first line, and I love the ASAM guidelines, they're great. There are, like I said, bupropion, mirtazapine, naltrexone are kind of the go-tos. The other things in the ASAM guidelines for methamphetamine are topiramate, which has, I think, terrible evidence, and it has real cognitive effects. So I haven't found a role for topiramate for methamphetamine. I think the best data for topiramate in stimulants are if you combine it with mixed amphetamine salts for cocaine, there's some really good data. Maybe if you have a lot of comorbid alcohol use, then topiramate might be something that you're reaching for. The other thing in the ASAM guidelines, of course, is methylphenidate or amphetamine type, more broadly amphetamine type stimulants. And that's a complex issue. There often are medical legal concerns around that. On a federal level, there shouldn't be, because there isn't any reason that we can't use amphetamine type stimulants for a substance use disorder by federal law. There is variation on the state level. Some states are more strict. For example, California is more strict than the federal level. So in my own practice, I can only use amphetamine type stimulants to treat attention deficit or a related disorder. I can structure a treatment plan such that one of the objectives of the treatment is reduced or discontinued methamphetamine use. And that's part of the measure of success of the treatment plan. So I can effectively treat the use disorder, but I can't be prescribing it as primarily to treat a use disorder. I can do that for 30 days, or I can dispense it as long as I want in a hospital. But prescribing it outpatient, I'm restricted to 30 days for if it's explicitly for a use disorder.
Philip, I feel like you preempted John's question about this later, so we might or might not get to it. But before, let's say the mixed amphetamine salts came up in the conversation, and you were going through your usual three, like your big three of the mirtazapine, the bupropion, the net plus minus naltrexone. Maybe could you share with the audience like how you have that conversation? Like what do you tell patients around the dosages for those, about where they start versus where they're going, and kind of how they might adjust starting, they're probably not going to start all of them at once, but how do you kind of initiate that conversation about follow-up and management?
Sure. The first is really trying to decide, are you going mirtazapine or are you going bupropion? Because they're going to be kind of the core. I'm an HIV doc, so it's kind of like, tenofovir is the core of most HIV regimens. You're going to either have mirtazapine or bupropion as a core, most likely. And which one I'm going to pick depends on why the person's using and some of the medical issues or goals that the patient has. If they use at night after partying and they are, and they have a BMI of 19, and I'm going to tend towards mirtazapine as a first line because you're likely to get a little bit of weight gain. It can help people sleep. And that's going to be my go-to for kind of that party situation. I'm also going to lean towards mirtazapine if they have a bunch of cardiovascular disease, because I don't have any cardiovascular contraindications like I do with bupropion. And in terms of dose, I'm going to stick with 30 milligrams. That's where the data are. It's a high enough dose to get some effect. But when you hit 45, you go from about 10% of people gaining weight to 80% of people gaining weight. And so I really worry about unintended weight gain. And if it's effective, you're going to see weight gain because they stopped using methamphetamine. You gain weight anyway. So that 45 milligrams of mirtazapine really worries me. I've had patients really plead with me to push it that high, and I've resisted, instead adding on other agents. For the bupropion, that drug is compelling for a lot of people, particularly younger people who are using methamphetamine. They have healthy hearts. They aren't dealing with out of control blood pressure. And they oftentimes are using methamphetamine to wake up and get things done. So bupropion is a stimulating drug. It's kind of like an agonist treatment. It's almost like a amphetamine type stimulant option. And it also is really good if they're smoking. So you can kind of hit two targets with one drug. In terms of dose, I try to push people up to 450 milligrams if we can. But most people, when they hit 300, they stop there. They don't really like the 450. It makes them too edgy. So most of the time I get people up to 300, they stop there. But if I can, I'll push it up to 450 because that's where the best data are.
And when you're following up with patients in clinic, how are you working with patients to decide whether these medications are helping or not? Because I do feel like in my practice, they help some, they don't help others. There is evidence, but it's not terribly strong evidence. So how do you balance in the messiness of this to prevent additional medications, that aren't necessary? We're internists, right? We all hate polypharmacy. What does that look like in your practice?
So my own practice is an outpatient HIV practice, and I'm dealing mostly with substance use issues in that practice. And I'm only in there every other week. So sometimes I would like to see people weekly, but I'm limited to every other week, which probably makes me a little bit less effective on some of these interventions. I would suggest, if you're starting a treatment like this, trying to see people weekly for a little while and then extending it to perhaps monthly, because you do need a counseling component in there. You do need to check in with them and see how their use is going. They need to know that you take it really seriously and that you're listening to them and that you're trying to work with them and give them additional ideas and strategies to deal with the temptations for relapse. Some patients, when patients are actively engaged and really interested in reducing or stopping use, you want to give them as much support as possible. It's not every day that you get somebody like that. In primary care, probably most of the time when we get somebody who's using methamphetamine, they're not really interested in stopping. So I'm going down that toxicity prevention route. And then they're coming back to me a month later saying, hey, if I really want to reduce my toxicity, I should probably reduce my use. And then once they get there, then I want to see them as often as I can manage it for a while. One of the things that I've started doing, and this is another outside of the box, I do not have much data behind it, is I send a high sensitivity C-reactive protein prior to intervening around their methamphetamine use. It's associated with methamphetamine use. Most of the time, not always, it's elevated when people are using regularly. And I found when people reduce their use, that lab value so far in a limited sample has always gone down. I don't have enough data to say if it doesn't go down, don't believe them that they actually reduced their use. I do not have the data to say that. Or that if it did go down, they definitely reduced their use. However, we know when you're working with somebody in a non-judgmental manner around their methamphetamine use, they tend to report consistently. They may underestimate their use, but they're going to underestimate it every time they report it to you. So if they say they went from a gram a day to a half a gram a week, they probably reduced their use. And if you have that high sensitivity CRP that went from 15 to 4, you can report back to them and say, hey, you say you reduced your use and that's fantastic. And I see less evidence of less inflammation in your body. So whatever you're doing, keep it up. Let's keep going in this direction. So I'll use it as a positive reinforcement tool when it comes back to support that.
I like these out of the box ideas, Philip. Thank you for them, and please keep them coming from expert opinion over here. But one thing I wanted to quickly gauge your thoughts on, or with the mirtazapine and the bupropion. Let's say you chose bupropion. When do you think about adding naltrexone in? You talked about those 3 as kind of the go-tos, but the first 2 being the decision about mirtazapine and bupropion. How do you make the decision to then introduce another agent, specifically naltrexone?
Sure. Again, it's going to depend on the unique patient situation. There are times when I'll start with high-dose bupropion and injectable naltrexone right out of the gate. Other times I'll start with bupropion titrated to the patient's desire, and we'll ride on that for a while and then maybe add on naltrexone. I'll add that psychiatrists often will use both bupropion and mirtazapine at the same time. They're way more comfortable with these drugs than us internists, and I think that that's fantastic. I wish I had done psychiatry. Also, it pays a lot better. So many reasons to have done psychiatry. But I do enjoy internal medicine and the rest of it too much to give that up. So in this patient, in John, let's say we started him on bupropion, and let's say he went from using a little bit each week to relapsing once a month. But he relapsed when he went out drinking with friends, and he had start using at 1 o'clock or 2 o'clock in the morning and use until the next afternoon and then go to sleep. And he was distressed about this, didn't want to do it anymore, wanted to increase his dose, but he's already at a high dose or he's not comfortable with pushing that dose higher. Naltrexone is a fantastic option. And in this case, I would think about oral naltrexone. And I would even potentially think about intermittent oral naltrexone. We know that intermittent oral naltrexone can help people reduce binge drinking. Really cool study we did in my shop. And we know that alcohol can be a trigger to other substance use, particularly stimulants, methamphetamine and cocaine late into the night. So in that case, I'd be thinking of an oral naltrexone as a trigger prevention tool. So on Friday, pop a naltrexone. And so when you go out with your friends, you have 1 beer or 2 beers and you go home at 12 o'clock and you don't end up using methamphetamine for the next 24 hours. In contrast, if he came in with a severe use disorder, maybe he's got really advanced disease and is really suffering and probably isn't going to take the bupropion on a daily basis because he's struggling with daily oral medication. His methamphetamine use is really inhibiting his ability to function or engage in medical care. Then he might be somebody that I think about combining the two and using injectable naltrexone right out of the gate based on the ADAPT-2 trial. And that patient, part of the idea there, that trial was really, might have been just a trial. It was a trial where they combined bupropion 450 milligrams daily plus injectable naltrexone every 3 weeks. So very intensive treatment intervention. It was the first trial that used that high dose bupropion and the first trial that got 70% adherence to bupropion. So we got good adherence to high dose bupropion. So maybe all our results were just from bupropion. Maybe it wasn't naltrexone. But I think we've all seen some people really reduce their stimulant use with injectable naltrexone. So I do think it works for a minority of people. It doesn't work enough for me to use naltrexone by itself because the trials of naltrexone by itself have been negative for stimulants. But in combination, I do think it benefits some people. And the other 2 things it does, it does kind of three things. It actually probably directly benefits some people. It intensifies a treatment. So there's sort of that placebo effect of getting an injection. And it means you're undergoing really intensive treatment. It's kind of like, an inpatient rehab type intervention. Whether or not the therapy is doing anything, the fact that you're engaging in a really intensive intervention helps drive you to stop using. And then the third thing is preventing that unintentional fentanyl use overdose event. By getting that opioid blocker on board, you might be saving the person's life.
This is awesome. And I think, as you said, we as internists, we are fairly comfortable with mirtazapine, bupropion. We use them for our other agents. And you really sort of work with the patient and tailor based on what's going on with their lives. Do they have any other co-occurring conditions, like they're working on smoking cessation? And you use that to guide which therapy you want to start with.
Exactly.
Wow, Phil, this has been great. And I know we teased a little bit to listeners earlier, but maybe we can kind of jump back into John's case as he is, telling you that he can see how crystal is negatively affecting his life. And he really wants to kind of start treatment and reduce his use. And he's asking you about a medication that he's heard that's been prescribed in the past for others for ADHD that helps, him maybe in concentration or might help his mood. And so just wondering how you kind of approach this question around mixed amphetamine salt prescriptions or prescribed versions of that for a patient without a clear diagnosis of ADHD or depression. But with a clear diagnosis of methamphetamine use disorder.
Yes. So if I was in a state with somewhat more liberal laws, I would think about this as a treatment for him. He's young, probably has good cardiovascular function, probably doesn't have contraindications, and he has difficulty concentrating, you mentioned. So this might be a really good option for him if he has some elements of potential ADHD. Of course, the true diagnosis of ADHD is you have to have it as a child,
Mm.
which makes it tricky when people haven't had that formal assessment and don't have a formal diagnosis as a child. That being said, we can give a tentative diagnosis as an adult based on some pretty simple screening techniques. So in California, if I was going to go down this road, I would deploy one of those screening techniques and see if he had a tentative diagnosis. If he did, and he was interested in this, I deploy these medications in a more sort of rigorous treatment program than I do medications like bupropion and mirtazapine, where I leave it a lot more up to patients. In this case, I would see somebody weekly or biweekly for a while until I felt like they were stable on the medication, taking it regularly, and had reduced or ideally ceased methamphetamine use.
And you mentioned earlier, kind of, Philip, that, ideally it's like contingency management first. Are there other components of psychosocial treatment that we should mention, especially if maybe folks don't have access necessarily to contingency management?
Some people absolutely benefit from rehab, and sometimes inpatient rehab is the best place to go. I would definitely recommend looking at what methodologies they use. The matrix model is a really good model that's actually got some data behind it, and CBT has data behind it for people with methamphetamine use disorder. Myself, I'll deploy sort of a CBT light modality in clinical practice, seeing people and trying to help them work through their triggers and how they deal with stressors in their life to avoid going down the path of using methamphetamine.
Awesome. Well, John's really keen to get your opinion on everything, including potentially kind of emerging treatments or things that you kind of might be thinking about as a researcher and clinician and somebody who's interacting with patients on the front lines. Are there things that you would talk about with John or resources potentially for him to consider as he's approaching his goal of reducing use and getting treatment?
Absolutely. So, of course, you want to look on clinicaltrials.gov and see if there's any resources there in your area. There's not a lot of places that do trials for methamphetamine use, and they tend to require weekly or even twice weekly visits. So they're difficult if you're not lucky enough to be in one of the locations that has a active trial. There are multiple drugs. And when I think about what I'll try for methamphetamine use disorder, I think about eating one of those meals at a Japanese ryokan where they serve you 45 dishes, and I'll try anything. Some of the exciting novel things that people are trying, there's some ketamine trials underway. There's efforts to test psilocybin, and we've all seen benefits of the GLP-1 agents or incretins for multiple substance use disorders. I've seen it in my own practice. I've seen it probably most profoundly with alcohol, and also seen it with cocaine and methamphetamine, where people start a GLP-1 agent for other reasons. I can't access it for a substance use disorder at this stage, but I can access it for obesity or diabetes and see their substance use melt away, sometimes incredibly profoundly. Other times I've seen the substance use go down, but not completely, and I've thought about combining it with a medication like mirtazapine, for example.
That's an interesting combo of what happens to people's weights on those two. Wow, so much learning. Carolyn, what do you think?
It sounds like addiction, it's just a really exciting time to be in the field, you know? Like,
Mhm.
I love learning about all of these new drugs that folks are looking into, other treatment modalities, and just learning to from you, Philip, some of the cool things you're trying and seeing in real time with your practices. So we appreciate you being here.
I like how you put that, Carolyn. This is an incredibly exciting time around methamphetamine and stimulants. We are way behind opioids, but at the same time, sometimes I feel nihilistic about opioids because fentanyl is so devastating and it has really kind of spoiled a lot of the progress that we had made in addiction medicine. It set us back huge. With stimulants, I feel like we are entering a vibrant era of discovery where we're testing multiple new medications and we are developing systematic approaches to address stimulant use. This four-tier approach, which I can't recommend enough, it completely changed how my patients dealt with this. I had so many patients who had no interest in reducing their use. And once we got to toxicity, they jumped on a statin bandwagon and then came back a month later asking about bupropion.
Mm.
So we have an opportunity to dive into a domain of care that has been terribly underdeveloped. And to me, that's really exciting.
And we appreciate you giving us these tools. I felt like when I was a resident and in training, I just didn't even know where to start. So I just ignored it, and have learned so much from you, other people along the way. So we appreciate your time. And I wanted to see, what are your main take home points for your listeners?
When you're assessing use, make sure you focus first on the benefits the person gets. Try to determine their cumulative exposure and binge pattern use. Think of stimulants more like alcohol in terms of how they harm the person than like opioids. They rarely cause a true acute overdose death. Tell your patients that you use a four-tier approach. Run through each element of it. It might take a couple of visits to get through everything. There's a lot, but give them the overview and run through each part. When you get to the toxicity prevention part, talk about a statin. Even if they're 26 and have only been using for a year and you're very reluctant to provide a statin, talk about it. It'll get them thinking about the toxicity. What you're trying to do for some people is just to get them thinking about the toxicities of the drug. And then they'll find their way to addressing their use. Other people, they should be on a statin no matter what, and you want to get that statin on board. And always be non-judgmental and be an ally to your patients. Recognize the barriers that they face. One of the things that I struggle with in addiction medicine overall is the fact that whenever we document somebody's use disorder in the chart, it's stigmatizing to them and potentially legally or financially stigmatizing. Most of my patients aren't going to buy independent life insurance ever. So it's not a big deal. But if they were, a diagnosis of a use disorder in their chart is going to make it prohibitively expensive. So recognizing the stigma that everything we do touching substance use imposes upon patients is really important.
Philip, I love that because I feel like it's a chance for us to also examine our own kind of actions and our own role in this and, what clinicians can do to destigmatize the interaction and the documentation. And I also love how you mentioned the kind of area that creates the patient's thinking, right? We didn't talk about readiness for change or kind of where people are or their motivations, but when you're going through that toxicity prevention, your fourth tier, it's really a chance for the patient to go, didn't think about that. And all we really want is for folks to just consider it, consider, and that allows folks to continue the discussion, and come back and talk. On the topic of continuing discussions, is there anything that you would like to plug? Any kind of resources coming out, trials, other things that you're especially proud of or really want for the audience to hear about?
I don't think so, actually. Not right now. I wish there was. I think there's a lot of exciting movements around the GLP agents, and hopefully some trials on that will move forward. 2025 has been a little bit of a slow year in the research world.
Well, thank you so much. That was amazing. I learned so much. Head's exploding.
Totally agree. I can't wait to use this 4-step approach probably tomorrow in my clinic. This will come up.
I would tell you, I wrote the article with Leslie Suen, and we needed a table. And so I created the 4-tier approach when I created this table. And then I went into clinic and tried it out, and it was mind-blowing. So I created it for an article, and then I tested it in the real world, and it was just a total game changer.
It feels like we should plug that article, Phillip. If there's a specific one that you want us to plug, that feels like a plug.
Yeah, so it's an article in New England Journal of Medicine Evidence by myself and Dr. Leslie Suen called Toxicities in Clinical Management of Methamphetamine.
Incredible. We'll be sure to link those in our show notes. And thank you again so much for being here.
My pleasure. Thank you all for having me.
This has been another episode of our Curbsiders miniseries, The Curbsiders Addiction Medicine. Get show notes at thecurbsiders.com/addiction. And if you're still hungry for more, join the Curbsiders Internal Medicine Patreon and get all episodes ad-free, plus twice monthly bonus episodes at patreon.com/curbsiders. You can find show notes at curbsiders.com/addiction and also sign up for our mailing list to get weekly show notes to your inbox.
We're committed to providing you with high-value, practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts, or contact us at curbsidersaddictionmed@gmail.com. A reminder that this and most episodes are available for CME credit for all healthcare professionals at VCU Health at curbsiders.vcuhealth.org.
And of course, a very special thanks to ACAM, the American College of Academic Addiction Medicine. Learn more about their organization at acam.org. A lot of folks helped out on this episode, so special thanks to our reviewer, Dr. Sarah Leidy, infographic Zoya Sarani, and of course, Dr. Ira Krishnaskaya and our entire Curbsiders team. Our technical production is done by the team at Podpaste. Elizabeth Croto does our social media. Jen Water runs our Patreon. Chris the Chu-Man Chu moderates our Discord, and Stuart Burgum composed the music. And with all that, until next time, I am Dr. Carolyn Chan.
And I'm Dr. Ira Krishnaskaya. Thank you for joining us today and letting us bring you some addiction medicine pearls.